Hi, Mike Gibson, Renato Lopez. We're talking to you live from ESC 2024 about the GUARD trial. There's a lot of strategies out there to detect asymptomatic AFib. One of the big questions is, if we do detect it, do we reduce stroke? So talk to us a little bit about what you found in GUARD, Renato.
Hey, Mike, thanks for having me. Yeah, so as you mentioned, I think the remaining question before we can really adopt screening as a systematic approach is really trying to show that if we do it, we can reduce stroke, because ultimately that's what we really want. So in GUARD AF, that's exactly what we did. So basically, we wanted to show that, we wanted to try to prove that hypothesis. So we plan to randomize 52,000 patients to either a screening strategy with a long-term continuous ECG monitoring device, the Zio patch, or usual care. And unfortunately, we couldn't get to the final sample size, so we end up randomizing 12,000 patients. Nonetheless, it's the largest long-term monitoring screening trial ever done up to date. And based on these numbers that we had, we did not show a difference in the stroke rates between screening and usual care. We did not show a difference in bleeding events, which was our primary safety endpoint. But in our exploratory outcomes, Mike, we did find an increase in 52% in the diagnosis of AFib. So we did show that screening with a longer monitor or longer or term continual ECG monitoring strategy finds more AFib, and also with an associated increase in the use of oral anticoagulants. So that was interesting to show and to confirm in a large trial, but not large enough to be able to detect a potential impact on stroke if that impact really exists.
Now, you did another trial where you did take patients with diagnosed AFib, this time through implantable devices, and did show an improvement in outcomes. So tell us why you think there may have been a difference. Was it just a power shortage or power outage here in your current study?
Yeah, so that's a great point, Mike. You are referring to the atRial trial that we presented last year at AHA.
Mm-hmm.
And in fact, with an implantable device like pacemakers and ICDs, if we really look at those AFibs that has at least 6 minutes of duration and not more than 24 hours, and we anticoagulate these patients, we show a 37% reduction in stroke. And importantly, in that trial, Mike, it was not just a reduction in stroke, but was a reduction in severe strokes, in bad strokes, whereas the increase in bleeding comparing to an aspirin strategy was an increase in not very severe bleeds, not fatal bleeds, not bleeds that led to hemodynamic instability. So really showing a positive trade-off, but very different population. Those patients have a mean age of 78 years old. These patients, because they have ICDs and pacemakers, they had much more comorbidities. They were higher risks for stroke. And we show subsequently that in the CHA2DS2-VASc, greater than 4 is really where the money is really where you get the greatest benefit from treating these patients compared to an aspirin strategy. So in GUARD AF, we look at participants, not necessarily patients, in primary care setting who were 70 years of age or above. That's it. So very different population comparing to the atRial trial. But you're right, they are related in terms of different ways to find AFibs, but really, I think showing that the risk profile of patients that we are looking for AFib really matters.
And the number of patients with AF tested in atRial versus the number of patients you detected in AF, here in GUARD? Was there a big difference in the sample size?
Yeah, so Artesia has over 4,000 patients, and everybody has to have AFib.
Right,
So remember, everybody has to have at least 6 minutes of AFib in the implantable device monitoring to be able to be randomized in the trial to either apixaban, an anticoagulation strategy, or aspirin. In GUARD AF, we show that actually the rate of AFib, diagnosed AFib in the screening arm was 5%. So only a fraction of patients who we screen in primary care setting will actually have AFib, and then a proportion of that will actually receive oral anticoagulant, because we also show, Mike, that most of those AFibs detected in the screening strategy, they were short episodes. Most of them were paroxysmal, and most of them were very short episodes. So, and then only a proportion or a fraction of that end up receiving oral anticoagulant. That's why, Mike, we really need the 150,000 patient study to really potentially show that if we screen broadly, you might have an impact on stroke. We don't know that yet.
right. Yeah, so I mean, here you had 4,000 patients, but here you may have about 600 patients or fewer who really got treated. So a lot smaller number, not the number we would like to see to really
Right.
test that question rigorously. Well, Renato, congratulations on a very well done trial. Thanks for sharing with us today, and thanks to all of you for joining us here at ESC 2024.
Thank you, Mike.